So we'll talk now about focal hypoxia and ischemia, which really is referring to a specific lesion of part of the brain. So I think we jump into talking about infarcted tissue specifically and what happens to those.
We talked about the global version of this, and now this is the focal. And really, when we talk about an infarct, we mean the focal hypoxic ischemic injury. If you go into pathology, you will hear a lot about dating of endometrial biopsies, which is very accurate, especially in the second half of the menstrual cycle. Day by day, you can tell from histologic changes what day of the cycle the woman is. It is not as accurate when it comes to brain infarcts, but it is something like that. There are multiple variables, of course, the size of the infarct, the collaterals, the metabolic rate, things like that, that will influence it. But by and large, first we start with something called red neurons, also known as eosinophilic neuronal necrosis or acute neuronal injury. And I will show some pictures of that. Depending on who you read and some variables, it will take 12 to 24 hours for those to develop post-event. So, but when you see them at the microscope, it means that it is the first sign of irreversible neuron death. So once you see red neurons, it's not coming back. But of course, this means that the patient should live after the event at least 12 hours so that we can see these changes. Otherwise, that will not happen, even though the neurons are still influenced. After 24 hours, now there is the infarction. The tissue is degrading, and 2 to 7 days, gradually, of course, not overnight, infiltration by neutrophils and some swelling. Eventually, the subacute stage, 2 to 3 weeks, all the way up to 6 weeks, where predominant cell type will be histiocytes or macrophages. And after 6 to 8 weeks, the entire cavity is cleaned up from debris by these macrophages, which go away when they are done. And around the infarcted tissue is intact tissue, but there is a lot of reactive gliosis. So therefore, after about 6 to 8 weeks, usually about 6 weeks, you end up with what is called a cystic or remote infarct. Sometimes it is also called a chronic infarct, but I don't like that term because it means that the issue is continuing for a long time, which is not the case. But I cannot tell you by looking at a cystic infarct whether it happened 6 weeks ago or 6 years ago. It's all done and it remains as a cyst. So let's see some microscopic images. Okay, here are the red neurons. Note that if we take the neuron at the middle bottom of the screen as a relatively normal one, that one, yes. So that is probably also affected, but it has not come to the stage to show these changes yet. But compare those pointed red neurons to that, and you will see that the crispness of the chromatin is gone. The entire cytoplasm is like a proteinaceous blob, eosinophilic material. And this is your red neuron. Let's see, I think an acute infarct is next.
Yep, here we go.
Yes, the one thing about infarcts is, and just like in demyelination, is these lesions are very well circumscribed. You can see the border between intact tissue and the infarcted tissue. The left side of the picture, the infarct, is now unrecognizable as any brain tissue. You have all this granular proteinaceous soup, if you will. And eventually macrophages will come in the subacute stage and clean it up. which we will see next. Here we have now all the macrophages on the right side, which is, of course, the lesional area. And note that a couple of arrows are pointing to reactive astrocytes in the immediate border of the infarct in the intact tissue. So there are a couple of things, just like in the demyelinating pseudotumor that we talked about in myelin material. Infarcts can also present with mass lesions, and especially this subacute stage is notorious for doing that. Especially in the frontal lobe, if the person doesn't have some, motor deficits or anything significant going on, may have some maybe personality changes or whatever. You can have a small infarct and it can continue evolving. And when it gets to the subacute stage, they tend to create this or result in this extensive peripheral edema. And that will result in a lot of swelling, and focal neurologic signs may develop, and people may show up at the ER. Radiology is very good telling these things apart, but sometimes we may get the intraoperative consultation material thinking that this may be a neoplastic process or some abscess or something like that. So, that is one good thing to know about subacute stage of the infarcts. So here is since it is a cyst and there is nothing to show microscopically, and we don't have a special stain for air, we put a gross picture showing on the right side of the picture a cystic cavity. This is the removed cystic, or as some call it, chronic infarct, that we cannot tell whether it happened last year or 5 years ago or what. And it will remain that way as long as possible. One other thing that I would like to point out, maybe too trivial for you guys for clinical practice, but note that the surface of the infarct, you can see a very thin layer of peel layer at the very surface of the brain on the infarct. Yeah, over there. That white line represents the leptomeninges and peel membrane, which remains intact despite the infarct right underneath it, because it gets its nutrition from CSF and meningeal vessels. So that is one important thing to tell whether this is truly a vascular process or a trauma-related process that comes from outside and destroys everything in between. So when you have that peel membrane intact, you can be sure that you're not dealing with a traumatic event. And we will probably talk about this more in the trauma lecture.